are interested in is what drives obesity in children, when and how do the comorbidities develop, and what are the mechanisms behind it, particularly with a focus on adipose tissue. Now, if you want to study what are the origins of obesity in children, you first need to know when you have to look at what is the critical age. And this is something where everybody has an opinion on it, but to answer that question, you need a decent data set, and that we are happy to have in Leipzig with the questionnaire cohort. So we ask, is there a critical age period when obesity clinically manifests? And we looked that up in more than 50,000 children. And what we found, if you look at it prospectively, so meaning you look at children and classify them for their BMI or weight status during childhood age, and then look what is the outcome in adolescence in terms of obesity. And what we found is that in the first years of life, the chances, so in infancy, the chances are 50-50. So if you have overweight or obesity as an infant, your chances are 50-50 that you either will stay overweight or obese or you will become lean. Now, by the age of 3 years already, the likelihood is more than 90% that you will stay overweight or obese if you are overweight or obese at the age of 3 or 4 or 5. So it means that this will not go away. And we also looked in what is the age where the highest increments in BMI during childhood, and we found that it's really the age between 3 and 6 years of life. So it's the early childhood that is the critical phase for developing sustained obesity. It does not mean that every adult had been obese as a child, but if you have obesity as a child, then the chances are really bad that you will stay obese. And the clinical implication of this is that we need to look at that young age, so not at puberty, well, also at puberty, but particularly this young age is of importance, and that we need to be aware of increases in BMI, so an upward crossing of centiles, of BMI centiles during early childhood is important. We believe that adipose tissue plays an important role. So what we found, for instance, is that paralleling that clinical increase in BMI, so between the age between 3 and 6 years, if we look into the adipose tissue of children, and we have a large adipose tissue biobank in Leipzig, we see signs of hypertrophy, which means that the adipocytes get bigger, storing more lipids. We see signs of inflammation, which means macrophage infiltration, and we see a disbalance in adipokines. And this is called adipose tissue dysfunction, and this adipose tissue dysfunction contributes to the development of the comorbidities that also develop early in childhood. So it does not mean that the children already have overt type 2 diabetes or myocardial infarction, but we do see the first clinical signs of these comorbidities to develop, like impaired glucose tolerance, increased blood pressure, etc. I think one very important thing is to remember that obesity is nothing that a person chooses, or that's the fault of the patients, particularly not of the children. We know that there's a strong genetic predisposition, even though if we are not that successful in identifying the genes that we could maybe manipulate. Maybe we will be there one day, but right now we are not. We know that there's an environmental contribution that acts, for instance, via epigenetic mechanisms. So this is something that can be hardly modified. You can't change your parents. So even though in large epidemiological studies, those classical risk factors like physical activity and nutrition and activity during the day, they are further down the list in terms of their effect and contribution to obesity. But those are the only modifiable risk factors that we have so far. And of course, yes, we do need to act on those risk factors. What we are interested in is really to find the mechanisms behind this. So, like if you imagine that, for instance, a low socioeconomic status is one of the major risk factors. So how does the adipocyte know that it's living in a low, deprived socioeconomic status? So there must be mechanisms, and we are interested in those mechanisms. And for that, as I said, it's a complex disease, so we need to approach it multidisciplinary. So we are looking into genetic factors, we are looking into epigenetic factors and how they interact with the environmental risk factors. And the second major focus is that we need to identify those children who are at highest risk for developing obesity very early and for developing the comorbidities very early. So not every patient is the same, and there is a subset of patients that is, I call them the early progressors, and we need to identify those, and we have to try to find means that we can treat those patients, maybe even with pharmacological treatment someday if we do find it. Obesity is also a societal problem, and we have to think of how we could change our what's called obesogenic environment, and that we have to do very early. That's not nothing that a patient or a family or a physician can do. We need to do that as a society, and of course politics have to engage for that. And otherwise, I think where the field is moving to, with many diseases, is that kind of individualized, personalized medicine, so that we need to identify those children who are at highest risk for developing early comorbidities or early obesity, and find what might be the best intervention for their individual situation, which may not be the same for every patient.